Hi everyone, my name is Janet Farrelly and I am here to discuss OCD. So we picked OCD and I'm going to go pretty quickly because there's a lot to discuss. But again, if you want a copy of this PowerPoint presentation, please feel free to reach out to me and I can give it to you without the talk over. All right, there's my email. So what am I going to learn? I'm going to tell you about the DSM-5 criteria, how it's diagnosed, the signs and symptoms, and how to treat. Non-pharmacological and pharmacological. So there's different screening tools, epidemiology, why does it target some people and not others, differences in symptoms and treatments across the lifespans, ethical and legal considerations, barriers to treatment, and positive and negative outcomes for patients. So this is all in the DSM-5. OCD is defined as repetitive and persistent thoughts, compulsions, and impulses that are cultivated and seen over time, and they're intrusive. They're not just, locking the door 3 times. This takes hours upon hours. Washing hands, affects the mental health of people. They count, they pray, and they really suffer throughout life. And it shouldn't be due to like a substance abuse such as marijuana or alcohol. And these thoughts are not random. They just come to the patient and they can't help themselves. And they spend an excessive amount of time doing these things. So a patient will wash their hands incessantly. They'll check the doorknob 50 times per day, and maybe they'll go back home to make sure their stove is off, even though they're 100 miles from the house. So this is different. OCD is different than repetitive thoughts that are common, such as, oh, did I lock the door? Or let me double click my key fob and make sure my car door is locked. These are severe. Person will make three hours to make sure their door is locked. In OCD, the thoughts are unthinkable and they're all unwanted. And it's also important to note that 50% of people who have OCD have suicidal thoughts. So how can we stop this? Because 10% of patients who suffer from OCD actually have tried to commit suicide. So the factors that protect against suicide in patients who have OCD is coping skills, family support, do they have hope for the future, impulse control, religious support, resilience, good social skills, a sturdy and robust self-esteem. So do they have religion to fall back on? Are they able to bounce back? Do they have resilience, social skills? Do they have good friends? Are they able to make friends and keep friends? So it's also important to know that OCD really disrupts a person's life. They have such a fear of germs, contamination. They'll miss a family barbecue. They won't be able to go to school. They'll be afraid of going into large crowds. And they'll spend hours of their day trying to focus on a specific task. So when an adolescent has OCD, you may see them wanting to stay home from school. They'll start checking obsessively that the door is locked for 3 hours. And when a person has OCD, it could cause them to lose their job, lose financial independence, be reliant to go back and live with their family because they can't keep their job because they're too busy checking things. So the pharmacological options is SSRIs, clomipramine, Effexor, clomipramine in combination with SSRIs, antidopaminergic molecules, and ketamine. Non-pharmacological is cognitive behavioral therapy, transcranial magnetic stimulation, hierarchy of fears, and deep brain stimulation. So what I thought was interesting for the treatment of OCD, you go much higher than you normally would. There's the maximum dosage of Lexapro, for example, is 20 milligrams. But with OCD, you could go up to 40 milligrams. So these are just all the different things. I left the reference at the end if you want to check. effects are clomipramine in combination with an SSRI. And the non-pharmacological cognitive behavioral therapy has been shown to be very promising. There's also transcranial magnetic stimulation, where it's an H-shaped coil, which can reach 3 to 5 centimeters, aims to target structures in the midline. And when I was doing this research, I thought the non-pharmacological, the best one is the hierarchy of needs. And this is when the patient is slowly introduced to something. So if they have a fear of reaching for a doorknob because it's full of germs, maybe they'll just go near the doorknob one day. The next day, they could go a little bit closer until they're finally able to use and touch that doorknob without having a complete, attack, a panic attack, or using a public bathroom, or they could even lead up to shaking hands with a person. So non-pharmacological is deep brain stimulation, and this is reversible. A surgeon implants electrodes in the neural circuitry, and you could see from here that it is reversible, but it has a success rate of 40 to 79%. Ketamine is also very interesting. 2 doses of ketamine for OCD were more effective than fentanyl given IM. All right, and their scores went up on the OCD scale from the Y box, and I'll talk about that in a minute. So this is the Yale-Brown Excessive Compulsive Scale, and this is just a test for OCD, and you could have a score of 0 to 40. So this is just a partial part of the test. But what I thought was interesting is you want these patients to be able to function again in life. And just even a little simple thing as gardening, is playing in dirt. It just, to me, it's so relaxing being out in that garden. And if we could get these patients to not have such a fear of germs, they could really enjoy hobbies that they never had before. So another test is called the Florida Obsessive Compulsive Inventory, and it also is part of a child's test. And they're pretty easy to use, pretty easy to follow. So for an adolescent, you could go over them. Your hands always have to be clean. Can you finish your chores or schoolwork? Can you not finish them because you're forced to do things several times over? Are you able to stop these thoughts? Do they interfere with your life? So the etiology of OCD, there's a strong genetic component, and there's certain genes. It's been shown in studies that if one twin has OCD, the chance of the other twin has a heritability marker of about 48%. And the gene called SLC1A1 has a big compactor as well. And as we all know, the corticostriatal thalamocortical loop, if that gets damaged or doesn't go the correct way, it can be one of the causes of the monotonous and repetitive thoughts. The basal ganglia is thought to be the part of the biggest cause. And also with this, you could have the Parkinson's disease, the chorea, traumatic brain injury, and Huntington's disease. All right. And it's been shown it's to be disrupted when OCD is present. And when this occurs, the globus pallidus and caudate could also be affected, and this could lead to OCD behaviors. So I thought it was interesting. The other etiology is, did patients have a distorted, imbalanced negative to begin with? Did they always fear contamination, harmful thoughts? This is what to look out for in diagnosing. Do they have to have symmetry? In children, something called PANS. It's an infection. It's a pediatric acute onset neuropsychiatric. So in other words, it's a streptococcal infection. And after adolescent has this, they tend to get OCD. It's an inflammation. So the ethical and legal considerations, I live in the state of Florida. In OCD, the patient is not necessarily a danger to themselves or others that would constitute a provider Baker acting them. Because if you Baker act somebody and they don't qualify, you're going to get sued. So even though OCD, they could have hoarding to the point where, it's a big fire hazard, that doesn't constitute a danger to themselves or others. Or, for example, a single parent who has guardianship of their 10-year-old daughter, while they may be at risk for losing custody, you can't Baker act them because they didn't say, oh, I have suicidal ideation. So the barriers to treatment I found in the African American population were that African Americans were less likely to seek treatment. And this is due to stigma, financial stress, costs, and also they tend to go to herbalists, support groups, spiritualists, or even chiropractors, and they may not believe in seeking treatment with cognitive therapy. And also, cognitive therapy is very expensive. It could be up to $200 a session. Okay, so this is the different factors that could improve the outcome or have a negative outcome as far as the psychiatric ARNP. So we have the cognitive behavioral therapy, starting on medications such as Prozac, Zoloft, or Effexor, working on the hierarchy of fears, having health insurance that covers the cost of CBT as well as medications. So 1 in 5 adults are living with some type of mental health issue, and there's a large deficiency in providers who are qualified to treat this. So as providers, if we are more qualified, that would be a positive outcome. The negative outcome would be the person may not believe in cognitive behavioral therapy. The patient may not deem that medications are necessary. They may lack the education to understand and working on hierarchy of fears could be helpful. They lack health insurance. Prozac, even though if you can get generic, but if you don't want generic, it's $664 for a 30-day supply. And there's a huge absence of providers who specialize in mental health care. So further, how can we advocate? Just in Florida, the bill was squashed by the Senate for us to practice autonomously. So we, as nurse practitioners, continue to advocate to practice autonomously as a psychiatric ARNP. Recommend the patient have CBT, SSRIs, tricyclic antidepressants. It's also important to teach the patients if they're unable to afford the psychiatric care or their medications, there are clinics that will treat the mental health issues at no cost, a sliding scale, and some who have insurance as well. Thank you. And if you, again, here's all the references if you want to take a look. And this is for the moving references. This is from Presenter Media. Thank you.